Hi, my name's Alexa Schooley. I'm a pharmacy intern. Talk to you today about a 62-year-old Caucasian male who presents to the ER with altered mental status, confusion, and vomiting blood. Patient has a 20-year history of alcohol abuse and was diagnosed with cirrhosis 6 months prior to today's visit. Patient is so physically impaired that he does not remember whether or not he consumed alcohol today, but according to his girlfriend, he has had multiple recent vomiting episodes which contain brown particles. Patient's past medical history includes substance abuse, alcoholism, hypertension, depression, and GERD. Upon physical exam, the patient generally seemed confused and mentally altered. The vital signs are as follows: blood pressure 145/88, pulse 110, respiratory rate 12, temperature 38.2 degrees Celsius, weight 100 kilograms, and height 6'1". Physical exam on the abdomen showed distended veins and softness and tenderness with the presence of a fluid wave, which is indicative of ascites. Lab findings revealed high ammonia levels, high LFTs, an H&H of 7.6 and 36%, as well as a blood alcohol content of 0.12%. After the patient was admitted to the ICU, an endoscopy revealed bleeding esophageal varices, and as a result, packed red blood cells and fresh frozen plasma were ordered. In order to reduce bleeding, the patient should be placed on octreotide 25 micrograms IV bolus, followed by continuous IV infusion of 25 micrograms per hour for 2 to 5 days. According to the labs, the patient's prothrombin time was elevated, so continue the vitamin K is ordered to improve clotting ability. Variceal bleeding is often a complication of portal hypertension. In order to prevent further episodes of hemorrhage, the patient should be placed on a non-selective beta blocker as opposed to the metoprolol succinate that he is currently on. So with this, discontinue the metoprolol succinate and initiate propranolol 20 milligrams PO twice daily. The patient is presenting with symptoms of hepatic encephalopathy, most likely due to increased ammonium levels. Lactulose should be given to promote ammonium excretion. Since the patient is NPO, rectal administration is most appropriate. Begin lactulose 200 grams diluted with 700 ml of water or normal saline via rectal balloon catheter. An increased serum creatinine and BUN upon admission suggests kidney failure, which is marked by hepatorenal syndrome. Normal saline 1,000 ml was ordered at 150 ml per hour to restore the kidney function. However, due to the fluid restriction based on ascites, the normal saline should be changed to half normal saline. As stated prior, the patient has Class C alcohol-induced cirrhosis marked by a Child-Pugh score of 14 and a MELD score of 36.7. To reduce ascites, the patient should be started on a loop diuretic, namely furosemide. Start with the bolus dose of 400 milligrams over 1 to 2 minutes, followed by a continuous infusion of 20 milligrams per hour. A paracentesis of the abdominal fluid showed blood cells and protein suggesting a possible peritonitis infection. So prophylactic antibiotic therapy with ceftriaxone should be started as ceftriaxone IV 1 gram every 12 hours. Metronidazole should be added as an adjuvant antibiotic, but only after the patient has abstained alcohol abuse for 72 hours. The initial dose of metronidazole IV is 250 milligrams every 6 hours and should begin when appropriate. The patient reportedly takes acetaminophen for pain relief at home. However, this medication should be discontinued to avoid further liver damage. The midazolam and fentanyl that were ordered should be continued, but the patient should be monitored closely for serotonin syndrome as well as oversedation. In general, the patient should be monitored for improved cognitive impairment, blood pressure changes, and respiratory rate regularly every few hours or so. Monitoring of CBC, LFTs, serum creatinine and BUN, prothrombin time, ins and outs, and changes in electrolytes should be monitored daily. Thank you.